Welcome to all of you. This is the webinar series of Health Systems Efficiency Group. Today, we are having Professor Bruce Hollingsworth. He is a professor at the Lancaster University, and he's well recognized as the authority, one of the authorities on the theme. And I request Bruce to take over. And our topic is measuring health and health care efficiency guidelines. Thank you very much. Welcome again.
Thank you, Pavitra. Can you see the slides okay and hear me okay? Yes?
Oh, good.
Because all right, thank you. Okay. Well, thank you for the invitation today to come along. I'm just moving the picture a little bit on my screen, because when you share the screen, it moves everything around a little bit. You'd think after using Zoom for 3 years, I would have the hang of it by now, but no. Okay, thank you everyone, and welcome to today's presentation. Now, I've got a few slides and a few things to say about guidelines and efficiency measurement. What I'd like though is some feedback as well. So if you could, if it's not a question, if you've got a point to make, I would be very happy if you drop that into the chat, and then I can see that later on. That would be fantastic. Thank you. I'll stop every now and then, or if Pavitra tells me if I forget, I'll open it up for questions. Hopefully you can all see that. So I think we'll just get going, Pavitra, shall we?
Yes,
yeah,
please.
I'll take that as a yes. Okay, good stuff. Off we go. Okay, so my name is Bruce Hollingsworth. As Pavitra said, I work at Lancaster University in the UK, and a lot of my research is around the area of guidelines and efficiency measurement. Well, a lot of my work's around efficiency measurement, and some of my work's around guidelines related to that, because as it turned out a few years ago, I was doing a lot of work in the area, and I wrote a review in 2008, I think it was, about efficiency measurement in health and healthcare. And there was a lot of variation with the way things were being done, and a few people, I think, had some thoughts about the usability and the usefulness, the use and usefulness of efficiency measures and productivity measures to different governments and to different bodies and who were commissioning such work. But the problem was there was a lot of variation in the way the work was done and conducted, and the software that was used, and the data sets and the ideas that people had about efficiency measurement. And so put together some guidance for this, and it's been revised a couple of times since, and it's actually just been revised again, and I'll give you the reference for that at the end. I was hoping it would be out by today, but it's not. It's going in a handbook, which I'm hoping will be out any day now. And you can email me at the end, and if you're very interested, I can send you a copy of the latest revised guidelines. So that's what we're going to be talking about today, and we've had a bit of feedback on these guidelines, and I'm just going to put that like that because it's just a bit easier for me to see. I hope that's okay. We've had a bit of feedback about these guidelines, which we've been revising for about a year now, or about a year to 18 months now, and we've presented this to the WHO and to different people, and we've incorporated the comments that we've been given in terms of revising what we've been saying. So just a little bit of background first. Now, a lot of you are part of the, I think you're all part of the efficiency measurement group, or if not, you should be, with I here. And so a lot of this you might know a little bit about, and that is that the efficiency is a stated goal for pretty much every country in the world in terms of their government, but it's also in lots of other capacities. Efficiency in health and healthcare is a stated goal for lots of NGOs, lots of non-governmental organizations. People like the WHO have it in their objectives: the delivery of effective services to full population, equitably, efficiently, and protecting individuals from catastrophic costs. So efficiency is in a lot of the objectives of a lot of governments and a lot of other organizations. To think about achieving the SDGs and universal healthcare and different objectives that governments and organizations have throughout the world, Efficiency is a stated aim and a stated objective for a lot of organizations around the world. Now, given that these objectives and given economic realities, there's a need and really a responsibility upon those of us who are asked to measure efficiency and measure productivity in terms of achieving something that's usable and something that's of use to people, to governments, to NGOs, and that actually does make a difference potentially. Now, efficiency measures are widely used in health. Okay, they're used at an individual level in terms of comparing different interventions. They're used at the level of comparing different hospitals across systems. They're used at a country level to make comparisons between different countries and how they efficiently deliver healthcare. They're used in lots of different capacities. And people like them and economists like them as well because they imply that you can produce more health without investing more. Okay, so it's a pretty straightforward economics 101 concept. Okay, they're used, as I say, in a variety of health and healthcare settings. And a little bit today, I'm going to talk about how they're used in low and middle income country settings and perhaps how we need to be thinking a little bit more carefully about when and how we use efficiency and productivity measures in LMIC settings. So the methods I think are useful. Obviously, I like them and I use them and I think they're useful. So what's the evidence for that? Well, I think there's lots of questions we need to ask ourselves. I mean, I'm an economist and most of you are, I'm guessing, as well. And we have to look at what the word efficiency means. Efficiency is just a word. Economists use it in a certain way. Other people use it in a certain way as well, and in different ways. So we have to define carefully what it is that we mean by efficiency and we mean by productivity when we're doing analysis of this type. So what is it that we mean by efficiency as economists? It's important to get the concept over of what it is that you are measuring. As part of that, we need to think about other definitions that we use in terms of being transparent when we do efficiency and productivity measurement. We have to think about what we mean by outcome measurement in terms of improving the health of patients or the health of populations, whatever it might be. And part of always producing guidelines is, are we moving towards some sort of gold standard of practice? Now, I think with guidelines, they're guidelines. We're not being prescriptive and saying you must do it like this or it is not acceptable. Okay, so bear in mind that these are guidelines for how to do something that's more useful and of more use to people. This isn't a way of saying you must do it our way or it is not a legitimate way of doing it, okay? But we're going to suggest some ways of kind of gold standard of potentially the way you should be aiming for doing things in a more useful way in terms of knowledge exchange and translating the results that we get into something that's useful for policymakers. Okay. And we'll look a little bit about what the issues are when we're undertaking work of this nature. Are there any initial questions, Pavitra? Obviously, I can't really see them when we're... Nothing so far?
No, not yet. Please continue.
Not yet? Okay,
no
worries. Thank you. So there's a lot of papers on efficiency measurement, a lot of journal papers, a lot of working papers. At 800 plus, I think it's probably 1,000 plus or more easily, looking at what we would class as efficiency or productivity measurement in health and healthcare. Now we can narrow that down to look at frontier models, which is kind of the area that I'm going to be talking about today in terms of measuring and benchmarking type of efficiency and productivity measures, so that at least we know a little bit about the concept that we're looking at and we're talking about. So it's not just any measure of efficiency that we're talking about. It's kind of benchmarking and frontier type measures of efficiency. So as we're economists and as we've published thousands of papers in this area, we should really know what we're talking about and what efficiency is. Okay. I should also know how to move slides on in a presentation, but okay, so where does the concept of economic efficiency come from? Well, a lot of people say it comes from this paper by Farrell in 1957 in the Journal of the Royal Statistical Society, looking at the measurement of productive efficiency. Okay, a lot of excuse me, a lot of economists say that's the starting point that we should read first. I think that's moved on a little bit. It's a great foundation, of course, a fantastic paper, but I think that's moved on a little bit. And we kind of talk a little bit now about the production of health and the production of healthcare. So I find this a very useful diagram to get over the way we're thinking about these things. And we talk about the production of healthcare first. So if you kind of concentrate on the top half of this diagram first, we have the inputs to it and the outputs from it, okay? So this is a pretty standard production function, okay? You have labor force time, you have capital and equipment and sundries and other things, okay? It goes into the production of healthcare, what comes out of things like hospitals, primary care, things like that. Is healthcare, okay? Generates a form of healthcare. But if we then feed that into the actual production of health, of course, healthcare is just one input into the production of health, okay? You have lots of other things. You have self-care, lifestyle, behavioral choices, okay? We have the healthcare system, okay? We have to contemplate the healthcare system. How do we account for that? The environment, of course, and lots of different things that contribute to the production of health itself. Okay? The ultimate outcome when we're measuring these systems is health itself, okay? Of which healthcare is only one thing. But the vast majority of the work that we do as economists in terms of efficiency measurement is the top half of this diagram. It's actually the production of healthcare that we look at, whether we're comparing hospitals, primary care systems, whatever it might be, okay? Dental care systems, anything like that, okay? It's the top half of this diagram that we tend to concentrate on. This is a diagram that lots of you have seen, so I'm not going to spend a lot of time on it. If you work in this area, you've seen 100 versions of this diagram looking at technical efficiency, allocative efficiency, and overall efficiency. It's just to demonstrate really that when you have a couple of inputs and a fixed output, we're measuring the distance from an efficient frontier of some description, okay? And if you're at point P, if you're that hospital, okay, and you've got a hospital at point R, then the difference between OR and OP is the distance you are from this efficient frontier, okay? And I'm sure I'm preaching to the converted, and lots of you have heard this already because you work in the area, but the efficient frontier in lots of cases, so if you're using something like data and development analysis or whatever it might be, this efficient frontier would be made up of the hospitals, if it's a sample of hospitals, which are operating in the most efficient sense. Okay, so that's what we're talking about when we look at efficiency measurement. Really, it's a measure of efficiency relative to an efficient frontier. So benchmarking is another word for it as well in terms of the way we discuss this. So that's kind of what we're talking about. Again, this isn't a lecture on efficiency measurement. There's lots of excellent books and references out there if you're interested in that. Okay, I'll just pause again briefly. Any questions or any points anyone wants to make or add? You're very quiet. Everyone's very quiet today. Okay.
There is one question. Does the efficiency
Oh, there's a question. Marvelous. Say again, Pavitra.
Yeah. So you can.
I was in the chat. Okay. Does efficiency equal maximum utilization? Well, most of the efficiency in the way we measure it, and as I say, people who use frontier type techniques, it's kind of relative efficiency. So it's not the absolute maximum utilization for what you have. It's relative to the way other people are operating that you have in your sample. So if you have 100 hospitals, you might have 10 which make up the efficient frontier, this efficient frontier, and the others may be operating a certain distance from this frontier, and that's the measurement that you make. So it's not absolute maximization of utility. It's kind of relative efficiency. That's the thing that we often measure in this case. Okay, so Farrell's a good starting point. There's lots of different techniques for measuring efficiency, but most of the papers that are out there, when you're looking at frontier measurement techniques, most of them out there, the majority use data and development analysis or some form of data and development analysis or non-parametric analysis. And there's a growing number which use stochastic frontier type frontiers or parametric type analysis. Okay, and there's lots of software out there to use this, lots of it free. Lots of it, you can do it, a lot of this in Stata now, for example, and different software packages that are available either very cheaply or free, especially if you work at a university. So there are lots of ways of doing that in a cross-sectional sense, and there are lots of ways of doing that, and now lots of means of doing it in a longitudinal sense with over time analysis. Which cards on the table now, I think is a much better way of doing it and shows you a lot more information rather than a snapshot of efficiency over time. So I think that's a lot more useful. Obviously, it depends on having a good data set over time as well, which we'll come to. Okay. Someone's saying in the chat, will you be elaborating more on decision-making units and choice of inputs and outputs? Yes, we'll be talking a little bit more about that. Okay, what does the word efficiency really mean? Well, you should all know this because you're in the Health Economics Association, so you should know what efficiency means in economic terms. Does it mean Pareto optimality? Does it really mean better? I guess this gets back to the question of that was asked about maximizing utility. So Reinhardt, an economist, an American economist, said use the term efficiency sparingly. Use it in a manner that cannot possibly be misunderstood. And I think that's cannot possibly be misunderstood. I think that's very important. You need to set up the concept first of what the efficiency is that you're measuring, okay, and then be very transparent about how you do it. Okay, so I think that's a key message for today, really. Tom Rice, another American economist, went further, saying Pareto optimality in a policy sense is actually not particularly useful. He asks what policy change would ever make someone better off without making someone else worse off. Okay, so I think once you're into applied economics and applied efficiency measurement in a policy sense, you have to start thinking about all of these concepts as well in terms of making your efficiency measurement as practical as possible. So saying all that, how should we go about measuring outputs? Okay, so I guess it depends what we are measuring. Okay, so the final output in the diagram I showed you earlier would be health. Okay, that'd be the final output, or some sort of intermediate output of healthcare. So if we're looking at a sample of hospitals, are we looking at throughput measures, number of patients seen, which might be case mix adjusted or whatever it is? Okay, are we looking at numbers seen, or are we looking ultimately at healthcare being an input to the production of health and changes in population health? So it's important to be clear up front what it is that is being measured, an intermediate or final outcome. Okay. Quality is very important. Case mix adjustment. You know, you can have an enormous number of cases going through a hospital, but you want those people coming out better or as well as possible. Okay, so you have to think about quality and quality adjustment. If you don't, you may be picking that up as inefficiency when it's not really inefficiency. It's a higher quality of output. I said I'd talk a little bit about low and middle income countries and efficiency analysis. And I think this is something that we've had feedback on and something that's been integrated in the new guidelines and the new guidance. And that is that there are certain points at which it's more useful to measure efficiency than it is at other points. I think when you've got very low income, I think this diagram helps illustrate that. If you're at a very low income level, okay, measurement of efficiency, you know, quantity of care, producing certain quantity of care and certain base levels of care and public health is what's important. Okay, a lot of access issues and establishment of the system, whatever that might be. Okay, so we have to think carefully about what it is in terms of efficiency that's being measured. We want to reach a certain level of care and a certain quantity before we start thinking about quantity-quality trade-offs, for example. I think in middle-income countries, okay, once you're at a certain level, quantity is still important. Access is important. There are still access concerns. Not everyone has access in every geographic area to every service that they would like. But quality is starting to become important, okay? And the curve starts to flatten out between money spent and quantity of health that's delivered. In high-income countries where things have traditionally been measured, okay, in terms of the vast majority of work that's been done so far as in high-income countries, really, you're not spending a lot of extra money doesn't increase the quantity of care a tremendous amount. What you're spending on is quality of care, so end-of-life care, improving people's, reducing people's level of pain, improving the quality of life of people by giving them hip replacements and different things. So it's really, quality becomes a lot more of an issue, okay? You're not increasing the quantity a great deal, but you're trading that off with quality improvements. And I think that's worth stating explicitly when you're doing efficiency measurement, and in the country and the setting that you're doing it, it's super important in terms of the type of efficiency that you're measuring, okay? And the inputs and outputs that you're putting in and the part of the systems that you are measuring. And the question in the chat, there are access concerns in the US. I think there are in every country. I know there are in the UK and Australia and other countries that I've lived in as well. There are access issues everywhere, I think, in terms of not just geographic access, but getting access in terms of the cost of care, for example, and different things like that. So I think you're exactly right, Kate, in what you say.
There is
so I think again,
another question. There is
go
another
ahead,
question,
Kapicha.
Bruce. Will you be elaborating more that other one?
Yes, I think I answered that one in terms of decision-making units and choice for inputs and outputs. Yes, we're going to talk about that in a minute or 2 minutes, perhaps. Okay, so yeah, I think there's a lot about the setting and transparency and the model that you're using, and we'll talk about inputs and outputs in a minute. Yeah, so there is always an argument if resources are scarce, which they are everywhere, but relatively speaking, in low-income countries, they're a lot more scarce. There is a compelling argument about spending money efficiently, but there's also a compelling argument about getting to a level where it's being effectively spent as well. And I think that's something that the WHO are looking at as well. Where does efficiency sit in relation to health system objectives? So access, geographic access, access to low-income people and people, the inequalities is a big issue, whatever country you live in terms of relative inequalities is a big issue. So we need to think about that carefully as well. There are lots of other objectives for governments alongside efficiency. Economists think it's, sometimes think efficiency is the be all and end all, but of course it's only one thing alongside a suite of objectives that policymakers are responsible for. Okay. Information on efficiency is powerful. We have a responsibility to get the information as accurate as possible and be as transparent as possible about what it is that we're measuring and what it is that we're not measuring, because the word efficiency has certain connotations and is taken as a very powerful argument. So in usefulness, efficiency is part of a framework for measuring health system performance. As we've said, there are lots of other things to think about. Access, as Kate said in the chat. In the context of specific areas of application, important work's been undertaken, of course. Lots of those studies that were made are very relevant and very important. But one thing policymakers wonder about, and in the feedback that we get, is how can studies be made consistently more useful? Okay, I think transparency is one thing, but also consistency of the way analysis is done and in different contexts is important as well. Issues that guidelines in general help with, guidelines about data, what data are used and what are inputs, what are outputs, for example. Objectives, what are the objectives of the study that you're undertaking? Is it to look at primary care or hospitals or countries or parts of countries? What is it that you're actually measuring in terms of performance measurement? Okay. So, as I say, we've had lots of feedback over the past year or 18 months, and we're almost ready to publish these. So any feedback you've got would be extremely useful. So use and usefulness criteria is something we came up with first when we were talking about guidelines and guidance in this area. And the questions we asked were, is there a way of undertaking research which would make this enormous supply of studies more effective, so more useful? Okay, we don't want people, well, people do it, but, you know, just doing studies for the sake of doing it, and, you know, have some data, must analyze that data. How about thinking, how can the study be actually really effective and useful in policy terms? So we thought, are there specific criteria or guidance or guidelines which would make efficiency measurement in general more user-friendly? And so we looked to establish some non-exhaustive criteria in this area to see if we could make efficiency measurement of more use and more useful to people. Let's say, remember, this is just guidance. Okay. So we couch this in macro and micro terms because we're economists and we've got a very limited vocabulary in lots of ways. So we looked at suppliers, okay, suppliers of efficiency measures, and we thought what could be useful in terms of the way people look at things in this area. So we thought any applied research needs to be placed, as we've said, in context, in a policy context. And we thought getting users of the efficiency measures involved at a very early stage, it helps ownership, but it also getting feedback at early stages helps what you choose as inputs and outputs that are most useful. Okay, it's no good going along at the end of an efficiency study and saying to people, well, there's your model, and them saying, well, yeah, but what about drugs? What about, you know, what about the equipment that we use? What about midwives? When you haven't included that at an early stage as an input, you know, or you've measured outputs in a certain way that actually isn't used in the hospital in a practical manner and an everyday level, you need to be giving people back really useful information. Okay, so feeding back the results at different stages as well, and getting ownership of the results. Okay, hospital managers are always worried about health authorities or government authorities using efficiency measures as some form of critique, the big stick, to take money away or to do something that's against what they want to get done. Okay, if you make it clear that what the value is that can be measured from efficiency, I think that's really important. Okay, getting people on board at an early stage to show them the value of the work that you're doing is really important. Health workers are interested. Okay, if you're looking at labor force efficiency, you know, does inefficiency mean less work or less employment? Is often a point that's been made to us. So again, it's worth reassuring at an early stage that you're looking at the relationship between inputs and outputs. It's not a cost-saving exercise usually, okay? Or if it is, you need to make that clear. Again, as you're going through, how are you giving your users the information that you set out to? Okay, ask them, okay, disseminate the results. Are the inputs and outputs, is the model right? Is this the model that's in there? Give the results back, you know. Is it a useful policy tool? Is it part of a suite of policy tools that are being offered to the organization? Okay. So are you on a micro level for suppliers? Are you asking the right questions? Okay. Have you got some sort of underlying theory of production that you're relying upon as well? Is your model specified correctly? Now that's very difficult with a lot of the models that we use in terms of statistically testing that. So we use a lot of sensitivity analysis with different inputs and outputs to see if it makes a difference to what we're measuring. Okay. So make sure you're testing everything to the max that you can so that you can be sure your model's specified correctly. Are your data comprehensive enough to answer the questions? Okay. Have you got any data on quality, as we said before? Okay. It's really, really interesting to have data on quality, I think, and quality adjusts the information we have. Now I'll just pause there because the question's popped up from John. Hello, John. I hope you're well today. I do know John, so I'm saying that. How do we create a balance between efficiency and equity? Well, I don't think they need to be mutually exclusive, but I think We need to just be clear that when we're looking at efficiency, we're looking at a certain aspect of the system. Okay. Policymakers, I think, often are very interested in equity and access and health inequalities and income inequalities and different aspects of a health system as well. So I think that they don't have to conflict. I think they can work in unison with each other, and I don't think there needs to be always an efficiency equity trade-off. Okay, I think they can work partly. You cannot be more efficient at providing equitable care. I don't think they're mutually exclusive, as long as we're transparent about what both things are measuring. Okay, so as long as we don't think of it as cost reduction all the time, efficiency is a relationship between inputs and outputs. Okay, both seeing both sides of the argument. So again, just going back to this, is the sample inclusive? Are you comparing like with like? I think that's very important. So if you have a sample of hospitals, for example, there is no point comparing, or no point usually comparing big teaching hospitals in a city with small rural hospitals 1,000 kilometers away. Okay, they're different types of production. You're producing something else in a different way. Okay, and what use is comparing that hospital that's, you know, a rural hospital 1,000 kilometers away to a big city hospital producing care and teaching medical students? You should probably be comparing it with other teaching hospitals and compare the rural hospitals with each other to see how they can learn from each other in benchmarking terms. Okay, so you have to have like with like comparison as well. What techniques will you use? Will you be looking at panel data? Now, I think that's really important because, as I said before, I think it's much more useful to look at efficiency changes over time and how policy interventions have impacted upon efficiency, rather than just taking a snapshot of efficiency at any one point in time. I'm never quite sure of what use that is to policymakers. I think it's much more useful to look at changes over time and to set up a system where they can look at changes over time as well. Keeping an eye on the chat and the time itself. Okay, we're in good time. Okay, so switching from the suppliers of efficiency measurement studies to the demanders, the people who are interested in seeing whether a study is of use. So we've come up with this checklist for people looking at efficiency studies to see if it is of use to you. Okay, so it's kind of a different angle for most people who do research in this area, but it's also a useful way for people doing research to think about the way demanders of efficiency studies and the people who actually use it do actually make use of things. So it's a way of thinking, okay, am I actually constructing something which will be of use? Okay, so I think two questions are pertinent here. Is the methodology appropriate? Are the results valid? Okay, and do the results apply in my setting? So if I'm looking at a study, is it something that's of interest, but is it something that's been conducted somewhere that relates to the work, to the healthcare setting that I find of interest and want to be measuring the efficiency of? It's unlikely every study will fulfill every criteria. So, okay, these are just guidelines and kind of a screening device to identify strengths and weaknesses of study relative to the area that you work in as someone who uses efficiency measurement studies. So what is this checklist? So the checklist, a 10-point checklist for assessing efficiency measurement studies. Okay. We took as a basis for this the well-known guidance for looking at cost-effectiveness studies, but we switched to look at efficiency measurement studies. So we asked, obviously, a series of questions. Is the question well-defined and answerable? Okay, so are the inputs and outputs clear? This looks like a Drummond checklist. Yes, it was. So we referenced it originally and based it on 10 points because they based theirs on 10 points. So we looked at that's an incredibly used many thousands of times system of checklist or a way of checklisting something. So yeah, we did reference that originally, and it is based on the kind of questions that they would have asked, but we switched to look at efficiency measurement studies. So is the question well defined and answerable, or the inputs and outputs clear? Very important when we're talking about inputs and outputs. This type of analysis are very data driven. Okay, they're 100% driven by the quality of data and the amount of data that you have. Okay, when you're looking at relative efficiency in this sort of setting, it's incredibly important to have data, good data, because if the data aren't good, or you have outliers or whatever it might be, that really is going to affect the results that you get. Okay, is there a particular viewpoint? What's the decision-making context? Okay, is it healthcare? Is it health? What is it that you're actually trying to model? Is a comprehensive description of the sample given? So when you're looking at a study of this nature, are there any relevant comparator units which think, well, where are they? Are they excluded from this study? Is the sample strictly comparable? So what we were saying just before, are you comparing teaching hospitals with rural hospitals, or massive hospitals with 1,000 beds with small hospitals with 100 beds? It's supposed to be a useful benchmarking exercise which will help you improve and make more efficient the healthcare system that you're looking at. So it has to be a sample that's very comparable. It's like with like or being compared. Are the quality and quantity output data clear? Who collected the data? Why? Is it case mix adjusted? Okay, is the hospital data that you're looking at adjusted for the severity of cases that are going in? Okay, are the quality data useful? Is there readmissions data? What is the quality data they're using that are used to adjust the quantity data within the data set? Okay. Are all the relevant inputs and outputs included? Is the range wide enough? Do they cover all the relevant viewpoints? Okay. Does it use physical quantities of inputs? So are there numbers of doctors and numbers of nurses, as well as costs of things? Okay, sometimes it's useful to look at both, for example, depending on what it is that you're trying to measure. Are inputs and outputs measured accurately in appropriate units? Okay. Is there joint use of staff? Or labour force information handled correctly and accurately? Are the units appropriate? Okay, are things are being measured in? Were things valued or weighted correctly? Okay. Lots of these systems have weights involved in them. So doctors are weighted in a certain way, and nurses are weighted in a certain way. Where do those weights come from? In a lot of the analysis that we use, like data and development analysis, the actual techniques come up with the weights that are placed on different inputs and different outputs. Were analysis over time undertaken? I think this is one of the critical points, as we've said. Were values adjusted to present value? Are the techniques used random effects, fixed effects models? Are you looking at scale? Are you looking at scope? What is it that you're looking at over time? But I think that's the most useful thing you can do, is monitor efficiency over time, whatever the setting is, countries, hospitals, primary care, whatever it might be. Do techniques add incremental value? Which technique did you choose to use? DEA or SFA or whatever it might be. Often people use all the techniques that are available. So they'll use DEA and SFA and use it as a type of, robustness check. You would hope that if you use both the efficiency measures, they might be slightly different numerically, but you'd hope they pointed in a similar direction to what was happening over time with the data you've got. If they don't, then there's something wrong with what you're doing, and you have to go back and check that, okay? So I think it's useful to use all the data you've got over time, and to also use different techniques as well. Maybe it's a robustness check for what you're doing. Was allowance made for uncertainty? Lots of sensitivity analysis is good. I think when you're using something like DEA, there are techniques for looking at statistical robustness, but they really are data dependent, a lot of the techniques that we use in frontier measurement, and we need to be very sure that the data we're using aren't skewing the results that we get too much in terms of outliers. Okay. Did the presentation and discussion of results include all of the issues of concern? Well, are they generalizable? Not every result has to be generalizable. If you do the hospitals in a specific country, that might be really useful information for that specific country setting. Not everything in life has to be generalizable, okay? Did you think about other factors, as John was saying, about equity and access and different things, okay? It's okay for efficiency measurement just to be one part of the story, as long as we recognize that, okay. So is there a gold standard, or in terms of guidelines? Well, we've got analysis we can do over time now using Lancaster indices and different things and SFA panel data techniques. I like the idea of using multiple appropriate techniques as a form of robustness and looking at trends over time. They would be my kind of gold standards, I think, to be thinking about and looking at. Any more questions, just put them in the chat and I can see it now, so I can pick them up. Thank you. So I think that we shouldn't forget the basics as well in terms of the gold standard. Data quality, what your inputs and outputs are and how they're specified. The sample size matters. You need a good, decent sample size to be comparing in terms of relative efficiency. And the quality and quantity of the data that you have are really important. Don't forget the basics. You can do all the most complex statistical econometric analysis in the world. But if you forget to get the data and the inputs and outputs and the model right in the most useful sense, it won't be of any use to the people who might actually make useful efficiency measures. I think efficiency measures do have real value, but of course I'm biased because it's the area I work in a lot of the time. I think they're a way forward. What have we found over the last 12 to 18 months when looking at updating the measures? Well, we found that they are useful in a policy context, and the criteria that we use have been adjusted so that they're maybe a little bit more useful. We found that there are means to interpret results, maybe not so much a checklist where all 10 things have to be done, and then if they're not, we dismiss that study, okay? There are criteria for means to interpret the results that are in front of you within the context that you want to use them. Okay, what's of use to one person, maybe of no use to another person, working from a different viewpoint in a totally different health system, okay? So it's guidance, guidelines for really judging the work that you produce in the most useful sense. And if you're looking at a study, for maybe thinking, is this of use to me within my setting, okay? They can help make the information of policy use. I think that's the important thing to bear in mind. So we've been reflecting on them, as I say, in terms of updating them. We've got some more practical recommendations now as well. The analysis efficiency really should be a regular routine activity. We've got some sustainable updated data. I think someone's just flicked their mic on by accident there. We've got some sustainable updated data are needed, okay? They're so data driven, we have to get the data right, but it has to maybe be repeated and repeated. So we would always look for new, updated, sustainable data collected regularly to make the system of efficiency as useful as possible. And this enables benchmarking. Okay? And that's what it's all about, I think, is to benchmark, see how others are doing things in a different way to you that might be of use to you in terms of improving the level of healthcare and ultimately the level of health that your system can produce. Okay, so we've worked with managers and we've worked with underperformers, and we really find this system is, although it's an ongoing changing system of guidance, it really is of use now. So the original guidelines have been used we reckon, in terms of the way we've measured it, over 1,000 times now in various ways, and things have moved on in terms of hopefully the quality and usefulness of the studies and the results that are available. And how can things be made more useful and more usable? Well, it's a movable feast. It's an ongoing thing, and we'll probably keep revising it as well. the latest draft of that. I was hoping it would be out and I could show you a picture of it. It's not quite out yet. It's a chapter in the Handbook of Productivity, Efficiency and Effectiveness, which hopefully will be out this month. Okay, so if you want a copy of this, I can send you a copy in advance if you email me. Or you can just hang on and buy the book if you want. But that is not a shameless advert for it, because I don't make any money off this, sadly, as an academic. But anyway, you can either read the book or you can send me an email and I'll send that to you. And as it's about 20 past, we've got a few minutes left. Jacob's asked a question. Thank you, Jacob. It's nice for you to say. Does case mix also include intensity? Well, it can. There's lots of different ways of measuring case mix. I think I might just make the picture a bit bigger. Yeah, there's lots of different ways of measuring case mix. Some ways of measuring it are incredibly complex and incredibly useful, and some aren't. But I think it's always useful to adjust the quantity of stuff that you're doing in healthcare terms by some measure of case mix or quality or whatever it might be. Okay. Thank you. Someone's put their email in. Well, I might get a copy of the chat, but just in case I don't, it would probably be more useful if you emailed me, if you don't mind, and then I can send you a copy. Thank you. So Pavitra, did we have any more questions or any more points that people wanted to make or discuss?
No, there is no more question. And please feel free if anyone is having any questions or interact with Bruce. We're having a few minutes more time left.
Oh, you can send me an email afterwards if you're a bit shy and you don't want to, and you don't want to talk in front of a big group of people.
And you are always welcome to give us the feedback and write us if you want something different and some new things for us. Thank you very much for your participation. Welcome you again soon.
Thank you all, yeah, and please get in touch, and thanks for the questions. I really enjoyed the interaction this afternoon, so thank you. Please get in touch.
So